You ask me how I know he lives. He lives within my heart. The next verse says, in all the world around me, I see his loving cheer. And though my heart grows weary, I know that he is leading in all the stormy blasts. The day of his appearing will come at last. Oh yes, you sound good. He lives, he lives, he lives. Salvation. Jesus lives today. He walks, he talks with me along the narrow way. He lives, he lives. Salvation. You ask me how. He lives within my heart. That last verse says, rejoice, rejoice, rejoice. Oh, Christians, lift up your voice and sing. Eternal hallelujah to Jesus Christ our King. Woo! The hope, the help of all who find. None other is so loving, so good. Let's stand. He lives, stand. Jesus lives too. Let's stand along life's narrow way. He lives. He lives. Salvation. You ask me. You ask me. You ask me. Turn around and look at someone. You asking me? I love God. You don't love God? What's wrong with you? He lives within my heart. Woo, let's give God a hand praise. Woo. Doesn't it feel good to be in this sanctuary, having what we used to call AY program, missionary volunteers? It feels good, and it's such a blessing that so many of us are still here this afternoon. We're going to ask Brother Mark for opening prayer.
Father in heaven, just grateful, Lord, for the day. You woke us up this morning, Lord, and we've been blessed with Sabbath school and blessed with church, blessed with the meal. And Lord, our cup runneth over already. And so we thank you for Dr. Hicks, Lord, and his willingness to present his expertise to us for edification, to build up your church, Lord, to know how to handle illnesses or at least facilitate, dear Lord, in the path of healing. So we ask for a blessing upon what's to be shared. Lord, may we assimilate it and be able to transmit it and throughout this church and throughout the community. This is our prayer in Jesus' name.
Amen. Amen. Thank you, Elder Minor. Before we bring Elder Hicks up to share, Dr. Hicks up to share, I would just like to introduce our health team. Our health team is called Living Well Health Outreach, LAHOO. And most of them are here today, and I want to acknowledge them because they've been doing a good job. And we kind of took a little hiatus when so much was going on. Church was in transition. And one of the things that has been on our agenda has been mental health. So we have Kayla Ramsey, we have Raven Perkins and Tamara Perkins and Danielle, and we have Dr. Hicks, myself, Nan. We have a big team, and I appreciate the work that our team does. And Dr. Hicks, we had already talked about doing health, starting off the rest of this year with mental health, and then he came to me and he said, let's see if we can get it going. And he works in mental health. He's a psychiatrist and a psychologist, right? Just psychiatrist. I thought years ago you told me you had both. Okay, whatever. I was so wrong. I apologize for that. Wash your feet the next time I'm, you know. But as we bring this presentation this afternoon, I want us all to keep in mind that the only person who can diagnose another person's mental health condition is a licensed practice professional. So there are terms that we sometimes use when we're discussing or, you know, sharing with people, and we really shouldn't, because we stigmatize people, and you're not able to help someone that you've already judged or criticized. If you already have a disposition about another person's personality, their whatever, you are unable to be of help to that person because you already have your mind made up. And as believers and Christians, we have to let go of whatever we are thinking and feeling and allow people to feel safe in our midst. Because the only way we can lead them to Jesus is they feel safe enough to ask us for help. You can't lead anybody to Jesus if they don't feel safe around you, if they already feel judged, condemned, criticized. You can look at someone and they can look back at you and they can say, I will never be accepted by that person. Our body language and just the way we talk to people. So without any more to say, Dr. Hicks, thank you for facilitating this program this afternoon.
Amen. Amen.
You need a podium? You need a small podium? You need a
I don't know if we have a small podium. Oh, we do. Oh, great. Okay. Well, good afternoon, everyone. As you can see, I'm going to do a Canva presentation here, so I don't want to be standing in front blocking the screen. So, but it's a pleasure to see everyone. Thank you for coming out and supporting. Oh, perfect. Thank you, Elder Meyer. Appreciate it. Okay. So I'm going to talk on bipolar disorder, a comprehensive review. So my goal with this talk is to just kind of have the church be just familiarized with the diagnosis of bipolar disorder and present some of the challenges, treatments, some of the just different statistics, and just increase our general knowledge about this kind of complex topic. And as you'll see in the talk, this is a relatively common illness, mental illness. So without further ado, why don't we go ahead and get started? Oh.
That way you can do both.
Sounds great. Thank you. Thank you, Elder Minor. Okay. All right. Let me first start with a little word of prayer. I know we had a word of prayer from the elder, but I'd like to pray again. Please bow your heads. Dear Lord Jesus Christ in heaven, please, Lord, first we just want to thank you for being with us, and we know that, Lord, all healing comes from you, and that you're the divine physician. And we just want to kind of edify the church with this talk, give a chance to answer questions as I'm able. Please remove me from this talk, and please speak through me. This is my prayer in Jesus' name. Amen. Amen. Okay, let's go ahead and get started. Let's see. All right, let me see if my clicker here. Oh, am I blocking? Okay, let's move over here. Okay, is that better? Can you see the screen a little bit better? Okay, great. Okay, now we're in business, except with this, the clicker. Okay, maybe I need to go this way. Up. Let's see. Not exactly even sure where to aim it here. Okay. To the back. Having a little technical difficulty here. Might be the batteries. So bipolar disorder. Is anyone familiar with the topic of bipolar disorder? And I'm seeing some nods, yes. We'll talk about it. Another name for bipolar disorder that has been used is manic depression. And people swing between two poles. There's a manic pole and a depressive pole. And so hence the name bipolar. Oh, perfect. It looks like it's working now. Okay. Thank you. Appreciate it, Brother Gerardo. Okay. Let's see. Oh, boy. The range? Oh, there it is. Okay. Let me move this a little closer here. Okay. Sorry about this. Technical difficulties. We'll get it together. Okay. All right, first slide. What is bipolar disorder? Okay. So, I have my little pointer here. And let's see if this is working. Looks like it's not really showing up on the screen. That's fine. So, just read it. According to the American Psychiatric Association's Diagnostic and Statistical Manual of Disorders, 5th edition, from now on, we're going to use the term DSM-5 because we're not going to say that, Bipolar disorder is a mental health condition that causes extreme mood swings, energy fluctuations, and difficulty functioning. So the DSM-5 defines bipolar disorder as a group of brain disorders that cause these symptoms to alternate between mania and depression. Okay, next slide. So let's get the definitions down for mania and depression. Mania. So mania presents with several different symptoms. We'll go through them right here. People who are manic, also displaying symptoms of mania, may have inflated self-esteem or grandiosity. Grandiosity can be when the people are feeling like they're a very special person, have special abilities, that they can handle anything, but in reality, they have difficulties. There's also can be a decreased need for sleep where they feel rested after only 3 hours of sleep or less. Now, normally, people aren't rested unless they get at least 4 hours of sleep, but with the mania, they're just so wired and up and full of energy, they feel that they don't need to sleep. Also, they can be more talkative than usual. There's this term called pressured speech, where they're speaking so fast, it's just hard to get a word in edgewise. And that can be a symptom of mania. Then there's flight of ideas. That's where their thoughts are kind of racing. They'll be thinking about so many different topics all at once, and it's difficult for them to finish their thoughts, to stay focused on one specific topic, and to sometimes communicate because there's so many different ideas in their head that they're trying to get out and express to you. So then distractibility is another potential manic symptom where they have difficulty focusing on one thing at a time. They'll be thinking about something, and then that will be gone within seconds, and they'll be on to something else. And these can all contribute to difficulty with functioning. Then there's an increase in goal-oriented activity, either socially, at work, school, sexually, psychomotor agitation, which refers to just purposeless, fidgety kind of activity. So they'll try to do many different tasks, different things, but they often will find that they're not able to be effective at getting these tasks done. And then another hallmark of mania is impulsivity, engaging in activities with a high potential for negative consequences. Spending sprees, infidelity, risky investments, all of those things can be seen with bipolar disorder. Okay, moving on. If you remember the two poles, one is mania and the other is depression. So let's go through what a major depressive episode is. I think people may be more familiar with depression. This is a depressed mood nearly every day, as indicated by the person's report that will say that they feel sad, empty, hopeless, or the people who aren't depressed around them may see that they're crying, tearful. That can be a sign of depression. Next is anhedonia, which is markedly decreased interest or pleasure in all or almost all activities most of the day, nearly every day. These are activities that the person previously enjoyed, but during the depressive episode, that enjoyment goes away. And then another sign, it can be significant weight loss when not dieting, or perhaps weight gain. So the weight loss has to be that they're not specifically trying to lose weight, and they just may not feel interested in eating. And it has to be at least a 5% of their body weight loss in a month. Or conversely, sometimes you can have kind of atypical depressive symptoms where the person's appetite will be increased and they will almost be binging. But weight loss is more common. So then there's insomnia or hypersomnia. Insomnia is a decreased ability to sleep. You're having trouble falling asleep, staying asleep. Hypersomnia is the opposite. You're sleeping too much. So the average person sleeps about 7 to 8 hours per night to be considered rested during the day. So if the person is getting, less than 4 hours of sleep or 3 hours of sleep or more than 10 hours of sleep, that can be an indication of some sort of problem there. That can be seen in major depression. And then we have psychomotor agitation or retardation nearly every day. That's observable by others. So psychomotor agitation is when someone is fidgety and just constantly moving. They may be feeling anxious, hard to sit still, but you can't stop moving. Psychomotor retardation. So that doesn't have anything to do with any sort of cognition or someone not understanding things. That just refers to slowing in this sense. So the person who's depressed can move very slowly. You may talk to them and they'll just be staring into space. They won't be processing information, and it's due to the depression. So these are symptoms of a major depressive episode. And I should mention, these symptoms, to qualify for major depression, you need to have 5 of these symptoms occurring over a 2-week period. Going back to the manic symptoms, you need at least 3 of these symptoms occurring over a week, or 4 if there's marked irritability, which we'll get to in a later slide. We'll talk about some other features of the mania. Okay. Let's move on. Okay, more symptoms actually of a depressive episode, and I'll just quickly mention them. Fatigue or loss of energy nearly every day, feelings of worthlessness, inappropriate guilt, which may be delusional. We'll talk about delusions. Delusions are a fixed false belief. So the person may believe something is true, but it may not in actuality be true. Diminished ability to think, concentrate, or indecisiveness nearly every day. And then finally, there's recurrent thoughts of death. Not just the fear of dying, but what we call suicidal ideation. Suicidal ideation is thoughts of wanting to harm yourself or kill yourself. So there's that, or there can even be a suicide attempt where the person tries to take their own life, or they develop a plan for committing suicide. This can all be seen with major depression. So next I want to talk a little bit about bipolar-related psychosis. Psychosis is basically a break with reality. So more than half of the individuals diagnosed with bipolar disorder experience psychotic symptoms during their mood episodes, so about 50%. And the main symptoms of psychosis to look for in bipolar disorder are hallucinations. So hallucinations are related to our senses. We have 5 senses: sight, sound, touch, taste, smell, and you can have hallucinations regarding any of those senses. So that's seeing things that aren't there, hearing things that aren't there, tasting things that aren't there, feeling things, maybe touching you or on your body that aren't there, and then smelling things that aren't there. And then the other symptom of bipolar-related psychosis that I've already touched on is delusions, which are kind of fixed, strongly held false beliefs that the person can develop. And these happen during the course of the person's mood episode. So that's important to remember for bipolar, and it distinguishes those psychotic symptoms from other psychotic disorders, which we won't really get into, things like schizophrenia, etc. Okay, so now we'll go to the types of bipolar disorders. So I use the DSM-5 as kind of my guide, and it lists 7 different types of bipolar disorders. If you look in the literature, some will say that there's only 4 different types of bipolar disorders. They may lump number 4 through number 7 all under the other specified bipolar and related disorder category. But you can see we have bipolar 1 disorder, bipolar 2 disorder, cyclothymic disorder, and then there's substance and medication-induced bipolar disorder, bipolar disorder related to another medical condition, other specified bipolar disorder, and then an unspecified bipolar disorder. I'm going to focus mainly on the top 3 as they're kind of the most prevalent. I'll give like a little sentence blurb on the other ones. So let's go to this first topic, which is bipolar 1. So bipolar 1 disorder, it's characterized by the presence of at least one manic episode during the person's lifetime. Remember how we talked about mania and some of those symptoms. That's all you need to meet the criteria for bipolar disorder. Just one manic episode at any point in the person's life. With bipolar 1, the person doesn't even need to have depressive episodes, although most people with bipolar 1 disorder do. There are a few people that just have manic episodes. So that's one of the criteria, one of the main criteria. So we've talked a little bit about mania, but sometimes in the patient's own words or in the words of other people that kind of observe them, they'll describe the symptoms as being euphoric, excessively cheerful, kind of almost being high, like on some sort of upper drug like speed or or cocaine. But this happens kind of naturally, by naturally meaning without the person using drugs based on their own brain chemistry. Feeling on top of the world. Many people kind of enjoy their manic phases, which can be an obstacle to treatment. They may feel more powerful, more, like they're getting things done, and they have these plans, and they may not want to go back to feeling normal, and they may not want to take medications, which we'll get to later. And it's an obstacle to treatment sometimes. So the moods may rapidly alternate and fluctuate. I've seen patients that had euphoria where they were just on top of the world, laughing, giggling, screaming, saying how happy they were, and literally seconds later crying, sad, or then switching and suddenly becoming very angry or irritable. So just the mood is just kind of all over the place. The mood changes are pronounced and a noticeable change from the person's normal temperament. So, this is a big change, usually noticeable by many people, especially with bipolar 1 disorder. And the person doesn't normally act like this unless they're in this phase, manic phase. Individuals may initiate projects or plans, but often fail to accomplish them. And again, that goes to some of the symptoms that they're having. And then an inflated sense of self-esteem is often present. Moving on for more symptoms, there's a decreased need for sleep. We talked about that. 3 hours or less usually, or maybe they don't sleep at all during the manic phase. Speech is rapid, loud, difficult to interrupt. That's that pressured speech. People may speak just continuously without regard for anyone's desire to kind of interrupt them. You'll say, slow down, I can't understand you. Wait, can I get a word in to answer your question or to make a comment? And the person will just keep going. And then also in conversation, individuals may have a flight of ideas where they abruptly shift from topic to topic and can be very difficult to follow because they're so disorganized. Also, there can be intrusiveness. People can be domineering, trying to control everything around them, control the conversation, control how the flow of their interactions with others goes, or demanding, asking for you to do things for them, demanding for you to do things for them, saying, you need to do this for me, you need to do that. I'm in charge here, I'm in control. You're going to do this, you're going to do that. And then poor judgment is often present. So judgment refers to the person's decision-making process. They may go on spending sprees, drug binges, giving away possessions, reckless driving, foolish business decisions, and then sexual promiscuity. And it should mention not all of these symptoms necessarily are present all the time. But if you see, 4 or more of these symptoms, 3 or more really, but 4 or more, if irritability is present, this may be an indication that someone possibly have bipolar disorder. Okay. So moving on, more associated features with bipolar 1. I'll just go through this quickly. Oftentimes, there's poor insight. So while judgment refers to a person's decision-making capacity, insight refers to their ability to understand what is going on with them and understand that they need treatment, that something is not normal, and that they need to proceed with the treatment plan. So that can be impaired, that they don't feel that they're ill or need treatment, and they may resist efforts to be treated. Sometimes there can be hostility, threatening behavior. There can be a lot of frustration during this time period because a person's trying to communicate many different things, has many different plans, not getting them done, not able to effectively communicate, or maybe they want people to act in a certain way and people are unwilling to act in a certain way with their demands or what have you, and then they can become hostile, frustrated, threatening. And again, we talked about the psychosis, that individuals may lose touch with reality. This happens about 50% of the time with people who are in manic episodes. And sometimes during those times, they can actually become physically assaultive, maybe even wanting to get into a fight. or even suicidal. And that can happen even without the person being psychotic. But if the psychosis happens, but if the psychosis happens, there may be even more of a risk of kind of unpredictable behavior and unfortunately violent behavior. So then catastrophic consequences can occur during a manic episode. Involuntary hospitalizations, arrests and troubles with the law, serious financial problems. Again, spending sprees are a big thing. So like you can give the manic person a lot of money and they go on a spending spree, and some people have blown, tens of thousands of dollars, went out and bought a new car, $50,000, $80,000 sports car if they have access to that money, and then, it's like, what happened? Where did all the money go? Oh, I spent it on this. So depressive symptoms may also occur, and if present during a manic phase, they may last moments, hours, or more rarely days. So that's kind of called a mixed episode when you have some manic symptoms and some depressive symptoms. They can actually both coexist together. And that's often maybe a sign that the person's kind of coming out of their manic phase and they're sliding into depression. So that's what I find when those mixed symptoms happen. So I wanted to also talk about rapid cycling. That's the presence of 4 or more manic episodes in a calendar year. And that's actually more common in females than males. There are some differences. I'll get to that in a later slide. There's about a 50-50 split between males and females in terms of having bipolar disorder. But males can have things manifest more in one way. Females can tend to have things manifest more in another way. There are some differences. I have a couple of slides and we'll talk about that later on. Okay, let's move on. Okay, now this is one of the handouts that I gave you guys. This is a mnemonic that's kind of helpful to, and if you want to look at that, you can look at it, helpful to remember symptoms of a manic attack, things to look for. And again, I'm not suggesting that you diagnose people or things like that, but if you're wondering if someone may be going through a manic phase or having, has bipolar and maybe manic, these are symptoms to look for. And this dig fast kind of refers to someone who's manic being generally sped up or they're kind of, very kind of all over the place. So you can picture them digging. If they have a shovel, they're digging really fast. And it just goes through the various criteria. So I'll just quickly go through. Distractibility, indiscretion, we've talked about all these things. Grandiosity, that's that exaggerated sense of self-importance and feeling like you have special powers or abilities. Flight of ideas, the racing thoughts, not able to focus on one task at a time. Activity increase, constantly on the go, doing different things, but not really being effective at getting your tasks done or what you want to do done. Sleep deficit, maybe not sleeping at all. Again, less than 3 hours. If you see someone sleeping less than 3 hours without any sort of drug use or anything going on, that might be a big kind of red flag that the person might be bipolar and experiencing a manic episode. And the last one is talkativeness. So let's move on. Okay, so that's bipolar 1. Now let's talk about bipolar 2 disorder. So bipolar 2 is a little bit different from bipolar 1. Bipolar 2 is characterized by hypomanic episodes. So hypomanic episodes can share many of the same symptoms as a manic episode, but they're less severe. So while the mania in bipolar 1 may lead the person to get hospitalized or, God forbid, get arrested or some sort of, really serious consequences, usually the hypomanic episodes, the person is able to kind of stay in control and they don't really have that happening during that time. So some people, I think Ted Turner might be a famous person who kind of has said he has bipolar disorder, probably this type. they find that during these hypomanic phases, they can actually perform better on the job. You know, they're not sleeping as much, but they can actually stay focused, hyper-focused, do a lot of work. Some of these people can really attain, you know, and it's in part maybe due to their bipolar 2 disorder. So there's a lot of talk about creative people feeling a lot more creative during these times and being very productive. And this hypomania may make them less likely to seek treatment because, you know, hey, I'm doing fine, and look at all this awards and the accolades and things that's going on. I'm getting things done, you know. But the impairment results from the major depressive episodes that come along with bipolar 2 disorder. So while bipolar 1 disorder usually is accompanied by a depressive phase, but not always, bipolar 2 is always accompanied by depressive phases, and that's where the dysfunction comes in. So that's like the opposite of this hypomanic period. So where they were once up, active, engaged, focused, then they're down. They're maybe sleeping all day. They're not active, maybe very sluggish, not eating, not able to concentrate or focus, you know. And that's where usually the problems kind of come in. Some of these patients may be in some sort of position at their job where even maybe in a leadership position, and then all of a sudden they're unable to function, unable to lead, and then people are kind of like, well, what's going on? What happened? I thought everything was going great. So that's usually when they come to for treatment. And impulsivity can be a big factor in bipolar 1 disorder and bipolar 2 disorder, but particularly bipolar 2, during these depressive phases, they can be impulsive, and unfortunately there can be an impulsive desire to want to commit suicide, and that sometimes can happen where they make suicide attempts. Also, substance abuse is common, really in both bipolar disorders, but bipolar 2 definitely as well. So let's move on to the next one. So next, cyclothymic disorder. Okay, so this is the third kind of bipolar spectrum type disorder. So while the bipolar 1 and bipolar 2 symptoms, so bipolar 1 symptoms have to last for at least a week. Bipolar 2 symptoms have to last for at least four days for the manic episodes, but hypomanic episodes for bipolar 2, manic for bipolar 1. Cyclothymic is more of a chronic, kind of low-grade, fluctuating mood that is beyond normal, quote-unquote, whatever normal is, normal expectations of mood. So you can see here, chronic fluctuating mood disturbance involving numerous periods of hypomanic symptoms and periods of depressive symptoms that are distinct from one another. And to make this diagnosis in an adult, this has to be happening for at least 2 years. So this is a long-term disorder. 1 year for children and adolescents. And it's important to note that because there's actually a fairly significant number of children and adolescents that may meet criteria for this disorder. And sometimes it's not recognized. If someone is, the child is very irritable sometimes, or then very down sometimes, or you don't know how they're going to be. They may just, you ask them to kind of do something, a chore, and they just go off on you, start screaming, and you're kind of like, what happened, This is something to consider. Symptoms usually begin in childhood or adolescence or early adult life. And then again, these just chronic mood swings, like beyond what you would expect of just kind of normal adolescence, overreactions to things, and discrete periods where the person where the child or young adult is overreacting, and this happens for a while, and then they may become depressed and not want to do anything. And the parents may be like, "What's going on? Is this a phase, or is this seems to be, it's kind of that control can be lost there in these moods." And for individuals that have cyclothymic disorder, there's actually a 15 to 50% risk that they will later go on to develop bipolar symptoms. So the thing with cyclothymic disorder is if it's caught early, it's treatable with medications, therapies. So this is something to consider, that maybe these mood swings in some children may be related more to this chemical imbalance. And we'll talk more about that in terms of treatment. Okay, when we get to the treatment section. Okay, let's move on. Okay, so these are the other 4 bipolar disorders that are mentioned in the DSM-4. Sometimes these 4 are all lumped together. I'm just gonna give like a little sentence blurb on each of them. Substance-related bipolar disorder, that's an elevated mood with or without depressed mood that occurs during or soon after substance intoxication or withdrawal or exposure to medications. So medications, drugs, like even street drugs, are in the picture there, and it's related to the substance. If you do a history and you find out that it's whenever they take this medication, this is when they have their symptoms. Bipolar and related disorder due to another medical condition. So this usually occurs during the first maybe 2 to 4 weeks or month and a half of the onset of another medical condition. Some conditions that are known to cause this can be Cushing's disease. That's a pituitary tumor. That's like it's a brain tumor that puts out a brain hormone. And that can cause this. Multiple sclerosis, MS, that's an autoimmune disorder that can affect physically the external nervous system and the central nervous system in the brain. Your body attacks kind of its own nerves and neurons, and it can cause a lot of problems. Bipolar disorder can actually be related to it, this sort of bipolar disorder. And then we have traumatic brain injuries, getting hit in the head and knocked out, car accidents. Sometimes after that, when people are recovering from that, they suddenly find themselves developing these bipolar symptoms. So, moving on to the other 2, there's this other specified bipolar disorder. So these are symptoms that don't meet the criteria for one of the previous bipolar disorders that I covered. Usually it's the time course. So keep in mind again with the bipolar 1 disorder, the symptoms are supposed to last for at least a week. In this case, they may last only for 2 or 3 days. And hypomanic symptoms are supposed to last in bipolar 2 disorder for at least 4 days. This may last less than that, but still you see some cycling, mood fluctuations. That may be this one. And then there's unspecified bipolar and related disorders. This kind of just doesn't really, these are all situations thought to be due to, or symptoms thought to be due to bipolar disorder that kind of aren't easily explained by other conditions. So there's seasonal patterns, like these symptoms may come up during the winter time, or you may have like a whole lot of anxiety, marked anxiety related to bipolar disorder in excess of what you would normally think you would see. And then, or atypical psychotic features, including catatonia. Just a brief blurb on catatonia. Catatonia is where a person, I think it was first really identified in schizophrenic people, they'll just suddenly freeze up. So like I've seen people walk into the doorway and they just get frozen in the doorway. And then they have what's called waxy flexibility, where, I mean, they're literally kind of striking a pose. You can move their arm or their limb, and then it'll just stay in the position that you move it to. That's called waxy flexibility. And usually that's kind of due to fear. The person is having some sort of psychotic episode where they think if they move, something catastrophic will happen. The world will end or they'll die. Usually we give them a tranquilizing medication to help them relax, like Ativan. And then all of a sudden you'll just see them, they'll start moving again normally after, like very shortly after you give them the shot. Normally not seen in bipolar disorder, but can happen. If it happens, it's an atypical or very unusual feature, and that would go under this unspecified category. Okay, kind of moving on to the pathogenesis. These are causes of bipolar disorder. So what causes individuals to develop this? Well, the answer is we don't really know 100%. The research is still ongoing, but we do know we have, we kind of know a little bit about it. There's genetic factors. So people with bipolar disorder, it tends to run in families. So in fact, if the individual, if someone in your family has bipolar disorder and they're your parent, your sibling or child, that's what we call a first-degree relative, then you might have a 9% risk of developing bipolar disorder at some point in your life and during the next year. That's about 300 times more than the baseline just general population. So in a given year, about 2.8 to 2.9% of people will just develop bipolar disorder. So if you have a family member, a very close family member that has bipolar disorder, that risk goes up to a 9% chance. And that's first-degree relatives. If, cousins, uncles, aunts, that's a little more removed, so it's a lower risk than that 9%. But it's still a little more elevated than the general population. So we see that. So it's genetic factors that we think are involved. Neurotransmitter imbalance. So neurotransmitters are chemicals in your brain that kind of help with thinking, help with mood, help with temperament. There's dysregulation, we think, of these neurotransmitters. Some examples of the neurotransmitters are serotonin, norepinephrine, dopamine. I'm not going to go too much into exactly what those things do, but know that there can be a chemical imbalance with those chemicals in the brain, and the medications actually kind of help to try to restore that balance. So that's how they're thought to work. Then there's psychosocial factors. So we think environmental factors play a role, and psychological stressors. We'll go through the stress inventory. That may play a role too. Some patients, individuals can be triggered. They can have their bipolar symptoms triggered, and high stress can do it. And they've done twin studies, like identical twins that have the same genetics, and one twin had bipolar disorder. If one twin has bipolar disorder, the other twin has a 25 to 40% chance of getting bipolar disorder, but it's not 100%. So that shows it's not just the genetics, because identical twins have the same genes. So there's these external factors that are also involved. We're not exactly sure how. So moving on. The prevalence of bipolar disorder. So I've talked about this, a little bit. This is how many people in the U.S. have bipolar disorder. It's diagnosed in roughly 2.8 to 2.9% of the population yearly, and about 4.4% of the living population will be diagnosed with bipolar disorder at some point in their lives. The actual rates may be higher than this because some people don't really come to the attention of the doctor. So it's thought to be at least about 3% of the U.S. population in terms of yearly diagnoses or yearly meeting criteria for bipolar disorder, and at least 4.4%, but probably more. And there's roughly equal numbers of men and women that have bipolar disorder. I think I've mentioned that. The average age of onset for bipolar symptoms is 25. But then it doesn't necessarily have to be 25. About 5 or 10% of patients, of individuals, have their first manic episode after age 50. So, or children. Children can be diagnosed too. It's most common around 25 for the person to have their first episode, but that doesn't necessarily, it's not necessarily the case. So keep that in mind. Okay, here's another slide. It just kind of talks about those same things that I talked about. 10 million, that's about the number of Americans that have bipolar disorder. The actual numbers may be a little bit higher than that. And about 83% of patients with bipolar disorder have severe symptoms. I'll talk more about this later on, but this is one of the reasons why it's important for bipolar patients to be treated, because there's some risks that come along with those severe symptoms that I'm going to talk about in a minute. And there's 4 different types of bipolar disorders. DSM's has 7, they're probably lumping in the last 4 bipolar disorders all into that one other category that I talked about. So anyway, let's move on. Okay, so I had talked about differences between men and women with bipolar disorder. So this is kind of interesting. Again, it's a 50-50 split, men and women, but men can present differently than women, and women can present differently than men. So men have a higher incidence of manic episodes and what we call unipolar mania. Unipolar meaning only manic episodes, not having the depressive episodes. Men with bipolar 2 disorder, again, think Ted Turner, the CEO of Time Warner, former CEO, I guess. They may be able to significantly function better in their daily lives than women with bipolar 2 disorder. I'm not really sure why that is, but some of that has been seen. Men with bipolar disorder have higher rates of conduct disorders and substance use disorders. So conduct disorder is kind of related to breaking the law or bending the law. They may have a history of arrests or rap sheet, that sort of thing. That can be seen with bipolar disorder. Again, there's this impulsivity that can happen, this indiscretions, so making kind of poor decisions, poor judgment. More likely to happen with men. And then men are more likely to use substances during their episodes. So compared to men, women are more likely to have actually bipolar 2, which is the hypomanic episodes and the depression, while men are more likely to have bipolar 1, the full-blown manic episodes, really out of control during the mania. But of course, both can experience both men and women. Women also experience more episodes than men. So sometimes men's episodes can be more severe when they get them, but women tend to experience more overall episodes. And I'm not really sure why that is. There are hormonal differences between men and women. It might be related to that. Women also frequently have reported rates of other mental health conditions along with the bipolar disorder. Phobias, which are considered irrational fears, panic disorder, anxiety, rush of anxiety that comes on can really affect a person's functioning in the moment. They feel really anxious, maybe scared. PTSD, that's post-traumatic stress disorder. That's after a traumatic event, you can keep reliving the event in various ways or have mood instability from that. Nightmares, flashbacks meaning you're awake, but you feel like you're reliving the very traumatic experience that happened. Eating disorders, bulimia, anorexia. So the bulimia is kind of purging, making yourself vomit, or taking lots of laxatives. Anorexia is where you just suddenly stop eating. Borderline personality disorder. That's a more personality-related disorder where the person can alternate between what we call neurosis and psychosis. So your personality is your mood. It's how you respond to a lot of different situations in life. Some people's very personalities can be considered pathological. That's one of those personality disorders. I'm not going to go into that, but that's kind of an interesting topic in and of itself. Okay, so among adolescents, the prevalence of bipolar disorder is slightly higher for girls than boys. Also, women experience more biological changes that increase their risk of symptoms. I talked about the hormonal changes, fluctuating hormones. Sometimes the bipolar symptoms can come and ebb and flow related to menstrual cycles. And menopause. Menopause may make bipolar symptoms more severe. But it's important to note these do not cause the disorder. So, there can be other things going on, but it's not like, oh, what's going on? Oh, she's on her cycle, so she has bipolar disorder. No, it's not that. Yeah, it's not causing it. So okay. It can just be related to it in people that have bipolar disorder, kind of pre-existing. Okay. Giving birth can also trigger symptoms, especially depression in women that have bipolar disorder. Women who have bipolar symptoms after giving birth are also more likely to have episodes following future pregnancies, and they're at greater risk of developing, it might be hard to see down there, but it says postpartum psychosis. We don't really have time to go into that, but that's considered a medical emergency. So psychosis is where the person loses touch with reality. I think I've mentioned that earlier. And that occurs usually about 2 to 4 weeks after the mother gives birth. If that happens, or if you think that somebody who's just given birth, a lady has psychosis, you want to probably immediately get them help, because there's a high risk of them harming themselves or harming the baby. Exactly. So immediately get them some help. Maybe try to have them hospitalized. You can call Child Protective Services, Adult Protective Services, even 911. So if there's one take-home point for that is, if you see a mother having psychosis around the baby, like out of touch with reality, that is an emergency, and you want to take steps to protect both the mom and the baby. So, okay. Children can get bipolar disorder too. I mentioned cyclothymia, which is kind of that lower grade bipolar, where they still have significant symptoms, but the fluctuations aren't to the level of a bipolar 1 episode or a bipolar 2 episode. I'll just go through just really quickly some of the symptoms the ways bipolar disorder can present in children. So it will be different than adults. You can read it here. Rages and extreme temper tantrums. Rapid change in mood over hours or days, easily set off by environmental or emotional stressors. Have a hard time waking up in the morning, don't want to go to school, don't want to do anything, don't want to eat. Defiant and oppositional behavior. Aggressive behaviors. Nightmares and or bedwetting. Sexual behaviors that are inappropriate. Obsessive or compulsive behaviors. So obsessions and obsessive OCD, obsessive compulsive disorder, is where a person will fixate on something. Sometimes they'll be cleaning, they can't stop themselves from cleaning, or they'll have a compulsion. That means they want to do some activity over and over again, which may not make sense. It's like, people like continually flushing the toilet, or, it's like, why are you doing that? I don't know, I can't stop. It's a compulsion. Daredevil behaviors can be seen in children with bipolar disorder. Interested in violent or morbid topics. It's interesting that can come up. Manipulative, excessively bossy, or bullying. Again, that can be some of the demanding behavior coming from bipolar symptoms. Or appearing excessively silly or goofy. Again, Some people will just laugh during these manic phases, or that euphoria. They'll just be and having that, and the children can have that too. So it's important to keep this in mind. If it's just one symptom of these here or there, that doesn't necessarily mean that the child has bipolar disorder. It's more of an overall pattern, and it's way out of what you would expect for the person. Like, you ask the person you ask the child, how are you doing? And then suddenly they just start yelling, but that can sometimes happen even, but but if that happens a lot, or if it seems to be related to cycles, or there seems like there's these ups and downs where one moment the child is flying high, and next moment they're very depressed, very down, I can't get out of bed, might want to investigate that. You can always take them to see a professional. Okay, so treatment of bipolar disorder, where medications. So medications are one of the mainstays of treatment for bipolar disorder. It's very important that patients take their medications, because this will be predictive of how their course goes. Without treatment, bipolar symptoms tend to get worse. But with treatment, patients can do well. They can have their, the sense of control over their lives back. They can function better with family members, friends, jobs. It's very important to take the medications. So this is you can see I've underlined it. Medication is crucial after a diagnosis of bipolar disorder, as it helps keep disruptive mood symptoms at bay. So this can help just restore the kind of orderly flow of life back again. So the immediate goal is to help stabilize the mood and reduce symptoms. And then once the mood symptoms are under control, it's important to remember this, that you need to encourage the person to keep taking the medications. People will often stop. They'll say, oh, well, I'm fine now. I don't need to take this. I don't like it. I'm getting like a little side effect or something. I don't want to take it. And then next thing you know, they're in another episode. No, you take the medications to get well and then to stay well. It's sort of like, I explain it to my patients, it's sort of like having diabetes. So, you don't stop taking your diabetes medications, because if you do, you'll get sick and go into the hospital. Same thing with this. You keep taking the medications so you don't get sick and go into the hospital. Okay, let's see. Oh, yeah, so, okay. Sorry. I'm trying to look and see where we are here. Okay, next. So I'm going to talk about specific classes of medications. Mood stabilizers, including lithium and anticonvulsant medications. These are a mainstay of treatment. So lithium, I don't know how many people have heard of that. You've heard of it? Okay, very good. It's actually, it's a metal. It's the lightest metal on the periodic table, and actually floats in water, if you can believe that. But it usually when found naturally, it's found in the form of a salt, linked with other chemicals. And it's been shown to reduce the severity and frequency of manic and hypomanic episodes, as well as lessen the thoughts of depression and risk of suicide. Interesting enough, one of my professors when I was in residency was the one who actually found that lessening of depression and suicide, the suicide risk, Dr. Bogos Yeravanian. So it was kind of interesting. He was the one that actually published the paper that he did the research to find that. So I know from working with him that lessening of the risk of suicide comes after 1 year. So the person needs to keep taking the medication. If it's less than a year, the lithium may not reduce the risk of suicide. Okay. Anticonvulsant medications. So they were originally developed for seizure disorders, but they help. We think they work in bipolar disorder, many of them, not all of them, some of them, to stabilize the mood by kind of reducing electrical activity in the brain. So I'm just going to just to get you guys kind of a little familiar with the names of some of these medications, I'm just going to talk about them. I'm not going to go into them. But examples of some of these anticonvulsant medications are Depakote, which is valproic acid, Lamictal, which is lamotrigine, and Tegretol, which is carbamazepine. Okay, and remember lithium too. Lithium's been around for 50 years, very long time. Works very well. There can be some side effects. We'll talk about that in a little bit. So let's move on. Treatment of bipolar disorder, antipsychotic medications. So antipsychotic medications nowadays are generally thought to also have mood stabilizing properties. Remember we talked about psychosis, that's where patients can have a break with reality. These medications can help restore the chemical imbalance so that they come back to reality. But they also may help to stabilize the person's mood. And we use antipsychotics a lot where I work. I prescribe these because they can work faster than the other mood stabilizers that I just mentioned. So it's not uncommon to start someone on an antipsychotic medication for mood stabilizing purposes or to treat psychosis if they have it. Remember, 50% of people that have bipolar disorder can have these psychotic symptoms, while the mood stabilizers start kicking in and working better. So they can work well together in as little as a few hours. So examples of some antipsychotic medications that may be prescribed for bipolar disorder, and many of these have a maintenance indication for bipolar depression. So, you know, sometimes people will say, "Oh, I'm not psychotic. I'm not crazy. I'm not going to take that." You know, but it has an indication for depressive symptoms of bipolar disorder. So, Abilify, Geodon, Haldol, Latuda, Risperdal, Safras, Seroquel, Vraylar, Zyprexa. Those are the names of some of those medications. I'm not going to go into that anymore. Okay. Moving on, antidepressant medications, anti-anxiety medications, sleep medications. So antidepressant medications are used to treat depression, duh, okay, that kind of makes sense. And they can be used, for bipolar depression. And so examples of some of these medications, again, I'll just go through the names to familiarize you with them. Wellbutrin, Celexa, Cymbalta, Effexor, Lexapro, Paxil, Prozac, Zoloft. Those are some common antidepressant medications. Yes. And then there's anti-anxiety medications that can reduce symptoms of fear, worry. Sometimes panic attacks can be seen. Examples include benzodiazepines. There can be some other ones like buspirone. We even use like some medications like Benadryl, which is kind of a low grade, or Vistaril. But these benzodiazepines have to be a little bit careful with because they can become habit-forming if you take them for long periods of time at ever-increasing doses, like over months. So the names of some of these benzodiazepines are Ativan, Klonopin, and Xanax. So then sleep medications may help with sleep. Remember, a big part of bipolar is that they're not sleeping most of the time, or less than 3 hours. So you can give them something for sleep, which actually helps. Lunesta, Rosarum, Sonata, Ambien. Those are the names of those medications. Okay, let's move on. Okay, on the more busy slides here, but I'll try to get through it real quick. Side effects can occur with these medications, but again, it's important to remember to encourage the person to keep taking the medication. Some side effects can be expected, and really, your body can get used to side effects. So I find many side effects go away. If the person's willing to stick with them for about 2 weeks and take them regularly, a lot of those side effects will go away. So normally I try to tell the person, okay, you may get a little side effect, especially when you're first starting it. Please stick with it because the symptoms of the disorder are usually far worse than the side effects. Side effects should be discussed with the patient's doctor, and medications should not be discontinued without notification of the doctor unless extremely severe. So I wanted to just mention some of the extremely severe side effects that can happen with these medications. They're fortunately rare, But if you see these side effects, this might be an indication to kind of stop the medication immediately. Excessive urination every 10 to 20 minutes. So that can happen with some medications like lithium. Very rare, very rare. In my practice, I think I've only had that happen twice, and I've been practicing, if you count the time I was in training, it's not 20 years yet, but it's getting close. So, yeah. So, but if you're going to the bathroom every 10 to 20 minutes, that can be a sign of kidney damage, which, you can stop the medication. Or vomiting every time the medication is taken. Some people report that with Depakote. So that may just mean that the dose is too high and you need to lower the dose. Painful bleeding rash in the mouth. That can happen with Lamictal, lamotrigine. That's called Stevens-Johnson syndrome. That's considered like a medical emergency. You want to stop the medication immediately because that can actually be life-threatening. Let's see, did I have another one there? Yeah, extremely high fever with confusion. That's more like neuroleptic malignant syndrome, which can be seen with antipsychotic medications. Again, very rare. I've never really had that in my practice, but I usually give the person other medications to kind of keep that at bay. I did have a colleague have that happen with a patient relatively recently. That's a medical emergency. Person would need to go into the hospital to get this. The high fever is usually like 102, 103, 104. And they'll be very confused during that time if they have neuroleptic malignant syndrome. Very rare, but a medical emergency. So those are like probably the most dreaded side effects of these medications. Again, very rare things to look out for with them. But I would recommend if they stop taking the medication, even if the patient gets one of these side effects, let the doctor know immediately. So as soon as their doctor's office opens, if it's like at night or something, call the doctor, let them know, hey, I've stopped the medication and I'm having this side effect. Okay, but so more common side effects of these medications can include diarrhea, constipation, some hair loss, maybe related to Depakote, but not always for people. I have the kidney and liver damage in there. As doctors, we monitor these things, so there can be blood draws that are associated with these things. And so we want to make sure that doesn't happen. Rare for that to happen, very rare, but it can occur. That's why it's important for these patients to go in and see their doctors regularly. Get the blood draw, check everything out, make sure the treatment's going well. Nausea, sexual problems, tremors, weight gain. So these can be more common side effects. With some of these side effects, like sexual problems, if some of these things, if you stop taking the medication, those side effects go away. There may be other ways to mitigate that. So it's not like people say, "Oh, am I going to be sterile?" No, it doesn't make you sterile. So okay. And let's see. I said, you want to notify the doctor immediately if a female patient becomes pregnant, because some of those medications I mentioned can cause birth defects for a baby. So I won't go into that further, but always, so if the person is thinking of becoming pregnant or trying to become pregnant, and taking bipolar medications, I recommend always let your doctor know. They may switch to medications that don't have that risk of birth defects, et cetera, if the person is taking them. And not all of those medications cause birth defects, but a few can. Okay, moving on. Okay, so the next mainstay of treatment besides the medications is psychotherapy. So studies have shown that patients do the best with a combination of medications and psychotherapy. The goals of therapy are to help people understand their illness and to provide coping strategies to help them deal with the challenges that they're facing. And there's 4 kind of main therapies that have been shown to be pretty effective for bipolar disorder. And so let me go through each of them in turn with a little blurb on that. There's interpersonal and social rhythm therapy, ISRT. This helps the patients, it's supposed to help the patient's mood by looking at their biological and social rhythms. And your body has certain internal clocks, an internal clock called circadian rhythms. That's usually disrupted with bipolar disorder. So things that wake you up in the morning, help you fall asleep at night. Bipolar disorder can completely wreck that. But this kind of helps the person be more attuned to that. Specifically, the goal is to kind of manage the disruptions in life, stressors, things like that, so that medication adherence and quality of life are improved. Okay, so moving on, CBT, cognitive behavioral therapy. The goal of this therapy is to kind of mainly help people with bipolar depression to learn to change negative thinking patterns, negative behaviors, and to kind of develop coping skills. So I won't go too much into that. But it's been actually found to be helpful and decreasing the relapse rate and improving depressive and manic symptoms along with daily functioning. Although other therapies may be a little bit more helpful overall, but it still works. Psychoeducation. So this is where you're educating the patient about the disorder, sort of like what we're doing now, so that they can understand causes, symptoms, prognosis, treatments, and take steps to kind of intervene, and make good decisions to get themselves on a good path. And again, taking medications is a very important part of this treatment. I feel like there's something crawling on me there. Okay, family-focused therapy. This acknowledges that bipolar disorder is not just difficult for the patient. Oftentimes, friends, family members, it's challenging for coworkers, for everyone kind of around this patient. And this form of therapy brings the family together, brings close friends together, and hopefully the patient comes to the person, and you want to work collaboratively to find ways to lower conflicts and to resolve them and to help the person's stability. This can be helpful even if the person who has bipolar disorder isn't willing to come in. So if the rest of the family is willing to set up an appointment for this type of therapy, of course, invite the person that has the bipolar disorder. But you can just get together and try to focus on ways to help this person deal with their illness. I recommend this therapy if the family really wants to get involved, which I do. Friends. We'll talk about support systems coming up. Okay, and this has been shown to be very helpful. Okay, moving on. Okay, these are other treatments for bipolar disorder. There's ECT, that's where they deliver an electric shock to the brain. It actually, it's used more for depression than bipolar disorder, but it can be tried for bipolar disorder. It might help. There's a lot more data for depression than bipolar disorder. Thank you so much for ECT. And then there's TMS, transcranial magnetic stimulation. So this is a kind of a newer way of stimulating the brain. It uses magnets to kind of send waves of electricity into the brain. This is thought to be helpful for depression. I wasn't aware of too many studies that showed how it was used for bipolar disorder. But you could try it if the symptoms are severe and nothing else works. And then hospital treatment. So patients, can be out of control, unstable, unwilling to seek treatment. In emergency situations, they might need to be hospitalized, even perhaps involuntarily, to make sure they're not a danger to themselves or others, or we call it gravely disabled, which is being unable to care for your food and or clothing and or shelter due to a mental illness. Okay, we're getting there, we're almost done. A few more slides and we'll be done. Lifestyle changes. So we'll just go through this really quickly. Doing a journal, a mood journal, can be helpful in kind of identifying triggers. Sticking to a regular routine helps. Practicing stress management techniques, that can be helpful. Creating a support network, family, friends, others, provide encouragement can be very helpful. Finding healthy hobbies to promote better sleep, reduce stress is helpful. And of course, we recommend not to drink alcohol or use recreational drugs. That can worsen bipolar symptoms. Okay, all right. So we're getting down close to the end of the talk. This is the Holmes-Rahe Life Stress Inventory. I think I promised when I spoke to the church before that I would just briefly go through this. I just have one slide on this. So this measures the level of life stress in a person's life. Sometimes people's bipolar symptoms can be triggered. High stress can definitely do it. And you can look, each stressful event on this list is given a certain point value, with the highest point being awarded to the death of a spouse, divorce, points being awarded to death of a spouse, divorce, marital separation, detention in jail or another institution, death of a close family member, major personal injury or illness, that sort of thing. And it goes down all the way to minor violations of the law like traffic tickets and jaywalking. So if you look, you're supposed to total up the level of stress, thank you, or the number of these events that have happened over the last year, and that gives you a certain score. If the score is 150 points or less, that can mean that the person's having a relatively low amount of life stress. By the way, this is a handout, so if you want to look at the handout, it's here. And you can look at it with me. And they might have a low susceptibility to a stress-induced breakdown. If the score is between 150 and 300 points, that implies about a 50% chance of a major health breakdown in the next 2 years. And 300 points or more raises the odds to 80% of a breakdown, or it can be mental health or medical, actually, in the next 2 years. Going through this, this doesn't really make any distinction between the two different types of stress. There's eustress and distress. Eustress is considered like good stress. Distress considered bad stress. So eustress, like you can look on this list, they have marriage is on here. I think most people find that marriage is something good, but it's still stressful, and you assign points for that. There's some other ones that kind of are good, like doing good at work and outstanding personal achievement. So these can be things that seemingly are good in your life, but can still cause stress and still contribute to your overall stress burden. So keep that in mind. And distress, of course, is considered like the bad stress, like negative events. Okay. So this can help professionals, medical professionals, mental health professionals, kind of identify stress in people's lives, and it raises importance about the importance of reducing stress. Now, this is just a tool. It's not meant to diagnose people or to point at them and say, okay, this you're going to have this coming up. I think you're going to have a breakdown, that sort of thing. Not necessarily. It's because it doesn't take into account how people deal with stress personally. And there's a lot of different personal ways that people can deal with stress. But it can be helpful as a tool to kind of identify your stress load and just maybe even take the test yourself and see how much stress you're under, and maybe try to think about ways to reduce some of the stress, because stress can have other negative effects on your body, including physical negative effects like hardening of the arteries, high blood pressure, etc. So that's basically that. So I wanted to give that to you guys so that you have that, and you can take the test yourself or give it to other people if you want. Okay. So this is pretty much, I think, going to be my last slide in the bipolar disorder, but this is a biggie. Life expectancy of people with bipolar disorder. So unfortunately, living with bipolar disorder is associated with decreased life expectancy. The average American is expected to live to about age 80. The average life expectancy of a person with bipolar disorder is unfortunately about 67. It's 13 years less. And the reason we think some of this life expectancy is lessened is because bipolar disorder, it's linked to changes like altered stress hormone levels, which again cause things like hardening of the arteries, these chronic conditions, high blood pressure, diabetes. It can cause immune dysregulation like autoimmune disorders, and then these brain structural alterations that can indirectly affect long-term health. A study in 2002 found that bipolar disorder may contribute to more rapid aging. And then there are some lifestyle factors that tend to go along with bipolar disorder. Remember, there's the impulsivity, the indiscretions. So increased rates of smoking, which is known to be bad for your health. Substance use, also bad for your health. Poor dietary habits, so fast food, junk food, just getting whatever nutrition wherever you can find it, not good for you long term. And then during the depressive phase, a sedentary lifestyle, not wanting to get out of bed, not moving. As humans, we were made to move, to interact, to do things, and then that's healthy for us. Be active, be exercising. They may not be doing that, and all these things can pose risks for chronic illnesses, medical illnesses. And then there's the unfortunate suicide aspect. It's a sad statistic, but unfortunately up to about 20% of people that develop bipolar disorder may go ahead and commit suicide at some point in their life. It's important to remember that's untreated, which is one of the reasons why it is so important for these bipolar patients to get treatment and maintain their treatment. Keep taking the medications, keep going with the therapy, and then maybe friends, family members, coworkers, people that care about the person. How the person can deal with suicidal thoughts and feeling is very important. And then also having a safe place in the home. So if there are guns in the home, making sure the person does not have access to them. Same thing with certain medications that they could overdose on, because a lot of these suicide attempts are thought to be very impulsive. So, it comes in, and if the person doesn't have access to something that they can easily kill themselves with, the feeling may pass. We're hoping that it will, or we're hoping that they'll ask for help, get help, treatment, and it's important to remember. Some people use the cliche suicide. It's a permanent solution to what is probably a temporary problem. So We want to, it can be difficult when you're in the throes of that to see your way out. But if you can stick with it, then hopefully, there are brighter days ahead. And ask, and don't be ashamed to ask for help. Ask for, reach out to friends, family. I'm mentioning that for the patients. Okay, and again, the last thing is a support network. Strong support circle of family, friends, peer support groups. Provide that emotional support and practical support. Okay. And then I wanted to put a little blurb, kind of what we know as Adventists about the new start. So these are some of our health principles, which can be helpful for bipolar disorder. I mean, think about all the things I've talked about. This is actually my last slide. But getting proper nutrition, exercise, water, sunshine, being temperate, and, avoiding these indiscretions, air, resting, Sabbath rest, trust in God. So these things are very important, and I think the people that practice this will lead to an increased life expectancy. And then the very last slide I have, let's see if it wants to go there. Okay. Resources. So I have some resources here that are available if someone may know someone with bipolar disorder or just want to find out more about the disorder or other mental health disorders. I've put that on there. SAMHSA. Blanking on the name of it. I think it stands for like substance abuse and mental health alliance. Findtreatment.gov, very good resource online. You can go online and find different sort of mental health professionals that can help with whatever problem the person is going through. And then we have the Suicide and Crisis Lifeline. You can call. I think all of these are available 24/7, 365 days of the year. So if someone's going through a tough time, and not just with bipolar, just in life, you can call these numbers. You can go on you can text, call, or go online to receive help, and they're there for you. That concludes my talk. Thank you, everyone.
Does anyone have any questions they want to ask?
Oh, there's a mic there, it looks like.
Check one.
And I understand that people have to leave, feel free, I know. But if you want to stay, I'm willing to stay for some question and answers. Yes.
Okay, so there was a slide for the symptoms of children. Are they being officially diagnosed as bipolar? Is there an age that you're able to diagnose them, or they could be diagnosed early?
Good question. So yeah, going back to the child slide, usually, so the answer is no. There's no specific age. It can be as young as 2 years old or 3 years old. There have been some kids that have been diagnosed. I'm not going to say that that's common or the norm, but I would recommend, if this is suspected that the child might have bipolar disorder, to go in and see a professional, child psychiatrist, or another mental health professional who should hopefully be able to help you with that.
One of your slides, you said it's mostly diagnosed at mid-20s, but there's some that don't even happen till after 50. Do
Yes.
Professionally in your practice, do you see maybe a pattern of maybe a life event that's happening maybe at that age to kind of help onset, bipolar disorder?
Good question. Yeah, well, it's interesting. There's a number of mental health disorders that can kind of come in at young adulthood or late adolescence, and I think bipolar fits into that pattern. oftentimes in our society, that's when kids are kind of getting out on their own for the first time, or maybe they're going into jobs or college or different things. So they're becoming more self-reliant. It can be a stressful time period, and stress can trigger some of these mental health conditions in susceptible individuals. So, yes.
Hi, I have a question about, you said something about using drugs can induce, bipolar
Yes.
disorder. What specific drugs, or are there specific drugs that people are taking that you find that this is happening?
Oh yes, I could say in my practice. I'm a jail and prison psychiatrist, so there's a lot of patients that use drugs, et cetera. So there's a few things. One, sometimes it's kind of hard to know if it's like a chicken or the egg thing, because patients with bipolar disorder can tend to use drugs. They can be more impulsive. So it can be difficult to know, did the drug use come first or did the bipolar disorder come first? But I have noticed that there can be an overlap there is conditions and drug use. In fact, there's a name for it. It's called dual and for your brain, and it's just beyond. Speed, acid. It really can alter your brain chemistry conditions. So, yeah, okay. Yes.
And one of the hardest things for us is getting them the treatment, because when they're having their manic episode, I'm good, I'm happy.
Yeah.
And because they have rights, when we sign them up for individual counseling or for their meds, they could say no. Right. But then I saw on one of your slides the family-focused therapy, and I'd never heard of that before. And so I'm wondering, based on your knowledge, are there a lot of practitioners out there that do that? Is it not a very popular thing? Why haven't I heard of it?
Oh. Good
Seems
question.
Like a great option
Good question.
for my kids who aren't going to individual to have their families to be able to have this kind of resource.
Yes. And you're right. Some of these therapies, we need to get the word out better. I work in the jail and prison system. Where I work, they could kind of have burned their bridges with family, that sort of thing. Although we do sometimes get, interested family members that are wanting to help. But I think it's important to recognize that these therapies are out there. And especially, you mentioned their children, adolescents. I would think the family would hopefully be very involved or want to be involved in their care and treatment. So yes, I would definitely recommend looking into it, maybe based on, I don't know if the parents have insurance or if they specifically have insurance. They can call their insurance company and try to set something up. Or if they don't, say they have just kind of Medicare or Medi or Medi-Cal. I actually gave out this handout, which has the local mental health clinics, and it's broken down by service area. It can be good to give them a call, like some of these outpatient mental health clinics, and they do have them. Usually it's run by like a psychologist or a social worker or a marriage and family therapist, MFT. But those services are available out there, and these clinics can link you into those services so you can get that. Yes.
Well, I'm originally from Mississippi, and I know there's a lack of resources. There's a lot of rural areas, a low socioeconomic status. Have you ever worked in a place where maybe bipolar depression was underdiagnosed because of a lack of resources? And what do you do in those cases?
Good question. Yeah, so for me, I'm a jail and prison psychiatrist. It is typically considered an underserved area, and it's difficult to kind of have people even come in and want to work with that population. I also have worked in the county clinic system a little bit. I worked in a rural county clinic out in Banning, which I don't know if you know where that is, but it's going out towards Palm Springs. There's like a casino near there, the Morongo Casino. And then I've worked up in Visalia, which is kind of near Fresno. So the services are more spread out in those areas, but they are there. It's maybe more of educating the families or patients, potential patients, about the resources that are available. And that's one of the reasons why I wanted to give this handout. So this shows resources in our area that patients can call and utilize. So, all right, any more questions? Okay, well, I think that should be it. Thank you, everyone. Appreciate it. Thank you.
Thank you, Dr. Hicks. A lot of information, but I'm sure everyone has at least one takeaway. And for me, I think the most important thing is that we have compassion for people, because no matter what someone is going through, that's not the person, that's what they're going through. And anything that we are going through, because of Jesus, we can come out of it on the other side, healthy, whole. God loves everyone. For the past 2 years, I've been taking classes through a Christian organization that is mental health coaching for churches, for faith-based organizations. And this program, it's so vital. The organization, they give these scholarships, and so a class that would cost $500 or $600, they'll have a scholarship where you're only paying like $29 or $59 for the class. And the purpose of this organization, it's called Light University. And the purpose of the programs is so that faith-based congregation can peer-to-peer support, so that the same thing he's saying, what he informed us of, he gave us the information, but this program teaches you how to come alongside of someone with these problems and help them get to the sources that they need. Now, girl, you need to see a therapist, but what can I do to help you get the help you need? That kind of thing. And recently I've been taking the courses in youth mental health coaching, but I'm not the person that's coaching the youth. I have no interaction with the youth. I'm available to help the person who works with the youth, the Sabbath school teacher, the teacher in the classroom, the coach, the Pathfinder leader. When someone says, Johnny just will not stay still, or little Susie, she's always hitting other kids. Well, there could be a reason for that. And so then, you ask that teacher, that facilitator, give me more, tell me more about what that child is doing. And then I can go back into the resources and find out, based upon those actions, what might be going on with that child. And one of the things that I learned is that 75% of our children, black and brown children, that have been diagnosed ADHD at the age of 5, 6, 7 years old, they shouldn't have never been diagnosed ADHD. Those kids our children are traumatized more than our children in America, black and brown children that live in the inner city, have been traumatized as much as children in Beirut, or where the Hamas and all these other things are going on, because they see gang violence, they live in violent homes, They see drug deals as they're walking back and forth on the street. You know, they see so much, and they are traumatized on a daily basis, our black and brown children. And so they're acting out, but then they're diagnosed because the teacher doesn't recognize what they're going through. They are diagnosed at an early age, ADHD. And they tell the parent, you know, I think your child needs, you know, and the parent goes to a family doctor, not a psychologist, not a counselor, but a family doctor will diagnose these children ADHD and put them on these drugs. And then they're on these drugs all the way through high school. And then they reach a certain age where they age out for medication if the parents don't have, you know, continuous health benefits. So now they're accustomed to being on drugs. Now they're out on the streets finding street drugs. And this happens to our children more than anything. So we need this type of information, and we also need the kind of training here in our churches to understand what's going on with our children, to love them, to not label them, not diagnose them, not ignore them, but love them and help their environment to be more safe and more healthy so that they are not put into a system of being on drugs from the age of 5 and 6 and 7 years old. Because once that drug is diagnosed, that drug is a part of their life. That drug for ADHD, or once they are diagnosed and they are given medication, that is a life sentence. That is a life sentence. So we have a work to do beyond just prayer and Bible study when it comes to our people. We really have to think about how are we going to be of help to people with their mental, emotional problems, not just spiritualize everything, not just turn a blind eye, you know. Thank you so much for staying with us till this late hour. I think it's been very informative. I think that we need more, and by God's grace, we will have more. Last thing I want to say is that our next health program is the Diabetes Undone program, which is eight weeks. It'll be on Sabbath afternoon for 8 weeks starting in October. We're going to look at how to reverse diabetes, prevent diabetes, and reverse diabetes. Because right now, diabetes is the fastest growing epidemic or pandemic or whatever you want to call it in terms of chronic disease. And once you are diagnosed diabetic, you're on a fast track to lose your heart, your kidneys, your pancreas, and your liver if you are put on any synthetic insulin. And some people use the insulin as an excuse to just do whatever they want to do. But while you're taking that pill or that injection in your arm, and you're still doing the same thing you used to do before, you are fast tracking for early death. So the Diabetes Undone program, we'll start advertising it soon. There is not a cost for the program, but there's a cost for the materials. There's a workbook and a cookbook, and we'll be talking about that, and we hope that you will be just as readily available for that program as you were for today. And we stand for closing prayer. Father in heaven, we are grateful to you because you said to us, if we lack wisdom, all we have to do is ask you for it. And you've provided us with enough information today, with enough resources today, for us to take action where it concerns any person in our lives, whether it's a family member, a neighbor, a friend, a coworker, that we can be able to be of some help in some kind of way. Open our eyes, God, and help us not to be like the priest and the Sadducee, or those folks that walked by the man that was by the side of the road and needed care. Let us all be good Samaritans, willing to help whoever, without regard to whom they are, because you told us to do justice, to love mercy, and walk humbly before you. And we just thank and praise you for this day. Bring us all back out here tomorrow morning at 7 a.m., please, God, before it gets too hot, so that we can begin this work of beautifying your courtyard and making this place a place that you can be proud of and that we can be proud of. We thank you and we bless you and praise you. In Jesus' name, amen. We will have a light breakfast for you in the morning. Come early so we can get the work done before the sun. Yeah, if you can come at 6, I'll be here. Come early tomorrow and help.